Welcome, everyone. My name's Andrew Organic. I'm a family emergency doctor and vice chair of the 2S LGBTQ plus member interest group at the CFPC. Today we've got a great webinar for you. The title is LGBTQI plus refugee health in Canada, what family physicians need to know. So to start off, I want to acknowledge the lands on which we are hosting this meeting, that they include the traditional territories of many nations. The CFPC recognizes that many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are now calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So just a bit about the webinar. So this is a collaboration between two member interest groups at the college. The Global Health Member Interest Group, chaired by Dr. Archana Gupta and Vice Chair Catherine G, and the 2S LGBTQ plus Health Member Interest Group, chaired by Dr. Thea Weisdorf and Vice Chaired by myself. It's part of a series of webinars, of incredible webinars that have been put together by the Global Health MIG. And if you haven't seen the other ones in the series, I would recommend that when you are done participating in this, that you go and watch them because they address some important issues. It is, in terms of the timing, we are hosting this on June 14th, which is part of the month that the month of June is recognized by many people as 2S LGBTQ plus Pride Month. This year is the first year that we are having hosting at the CFPC, CFPC Pride, which is a month-long event to support family doctors providing care to 2S LGBTQ plus persons, to highlight the incredible work being done to build and strengthen the health of 2S LGBTQ plus Canadians, to raise awareness of the inequities and barriers that 2S LGBTQ plus communities face in accessing and receiving healthcare, and to celebrate 2S LGBTQ plus family medicine across the country and within the college. A couple other housekeeping notes. The webinar is certified for 1 Main Pro Plus credit, so make sure that you do an evaluation at the end. It will be available in the chat, and you can claim your credits. And also there is a Q&A function on the chat, so at the end of the discussion, there will be a Q&A session that hopefully we'll be able to get to your questions. Just submit them in French or English in the Q&A function on Zoom. Why we decided on this topic is it's a very important area of intersection for global health and 2S LGBTQ plus health. LGBTQI plus refugees are a growing community in Canada, and the government of Canada has been working hard over the last decade to bring in people from these communities from around the globe. I've included a couple of quotes here that speak to this from the National Minister of Immigration, Ahmed Hussein, and Randy Boissonneau, the Special Advisor for Prime Minister on LGBTQ2 issues. LGBTQ populations around the world face ongoing challenges due to discrimination and criminalization based on their sexual orientation, gender expression, and identity. Our government has demonstrated a leadership role through commitments to advanced human rights and to safeguard vulnerable people. We will continue to stand up for LGBTQ LGBTQ2 rights, both at home and abroad. So this is a growing community and an area of great importance for Canadian immigration and health in our nation. And as family doctors, we need to be ready to support these communities. So this talk is going to be about what family doctors need to know in caring for LGBTQI plus refugees. We've been able to put together an incredible panel that can speak to different aspects of LGBTQI plus refugee health. Dr. Ian Armstrong, Mo Akal, Nishan Nathwani, and Simran Kaur. All speakers have received an honorarium from the CFPC, and each of our panelists are paid employees of the organizations where they work. The program itself has received financial support from the CFPC through a member interest group section project grant, and has received in-kind staff support from the CFPC. The potential biases were reviewed by the Scientific Planning Committee and are not relevant to the content included in the program. Just a couple terms that I want to address. When we use the term refugee, we're talking about a person who's forced to flee from persecution and is located outside of their home country. You'll also hear us use the acronyms 2S LGBTQ+ and LGBTQI+, one to speak to our MIG and greater global community, or the community in Canada, and one to speak to the refugee population in Canada. In these acronyms represent a broad community with a diverse group of sexual orientations, gender identities, and gender expressions. In the versions that we use, 2S represents two-spirited, L is for lesbian, G is for gay, B is for bisexual and non-binary, T is for transgender, Q is for queer and questioning, I is for intersex, and the plus represents many others, including asexual and pansexual. So our panelists for today, I'm going to introduce them in no particular order, and give them the opportunity to speak to their role in supporting LGBTQI plus refugees. So first, Dr. Ian Armstrong is a family physician in Toronto with a focus on LGBTQI plus individuals and people living with HIV. Ian, if you could speak to more specifically your role with refugees.
So I have a general family practice, but as part of when I was starting out, identified that an area of interest was HIV, primary HIV care, and transgender care. And so as part of building a practice in downtown Toronto, close to the gay village, I did have a number of refugees who either found me or were referred to me. And so was lucky enough to be able to meet some of the needs of that population. And then outside of my work at Maple Leaf Medical Clinic, I also do part-time work out of the Hassle Free Clinic, which is a drop-in sexual health clinic that's very low barrier. And so as part of that, the public health mandate means that I'm able to see people who are uninsured or don't have provincial health care. And so that sort of is a bit of a different demographic than what I'd encounter in my regular clinic.
Fantastic. We also have Mo Akal, who is a settlement manager at the Alliance for South Asian AIDS Prevention, supporting LGBTQI plus refugees adapting to their new environment. So Mo, if I could get you to talk about your role with LGBTQI plus refugees.
Of course. So good evening, everyone. It's a pleasure to be here tonight, and I hope you absorb as much information as possible. So my name is Mo Akal. I go with the pronoun he, him, and I'm the settlement manager at the Alliance for South Asian AIDS Prevention. And basically, I help conventional refugees, protected persons, and new immigrants to Canada. Most of them are members of the LGBTQIA+ community. And most of them, like the ones I deal with, my service users are coming from the Middle East and South Asia. And recently, we're also helping the Ukrainian refugees. And the services that we provide are translation, interpretation, referral to the right resources, help with transportation, connecting them to family doctors. And we do a lot of webinars on different topics. So that's a brief summary.
Fantastic. Nishan Nathwani is a senior advisor to Rainbow Railroad. Also previously worked for United Nations Refugee Agency on the protection of gender-based violence survivors and LGBTQI+ refugees. Welcome, Nishan.
Thanks very much, Andrew. It's really great to be here. So as you mentioned, I'm the senior advisor at Rainbow Railroad. And for those of you who haven't heard of us, we are an organization based out of Toronto with a second office in New York that provides direct assistance to LGBTQI people worldwide facing persecution to find permanent pathways to safety. So we do that mainly through formal state resettlement programs, but we also increasingly use various other complementary pathways, humanitarian visas, to try and get as many people to safety as possible. Just to put that in context, we are on track to receive 10,000 requests for help, individual requests for help this year from people facing persecution. And as you mentioned, Andrew, previously I worked for UNHCR, the UN Refugee Agency in Switzerland, Lebanon, and Greece. So a bulk of my field work and insights actually come from that earlier phase in my career. So happy to be here, looking forward to the discussion.
Fantastic. We also have Simran Kaur, who is the Linkage to Care Coordinator for Fife House and the Blue Door Clinic, providing case management and service navigation support to LGBTQI+ community members living with HIV, many of whom are refugee claimants. Simran, can I get you to introduce yourself?
Yeah, of course. So my name is Simran. I'm the coordinator for the Linkage to Care program at Fife House. And Fife House is a nonprofit. It is a housing and case management service provider for people living with HIV. And my program specifically provides intensive community-based case management to individuals living with HIV, but who identify as racialized is the priority population for my program. And so I do work with a lot of newcomers because I work directly with immigration clinics where folks are often tested positive for HIV. And I'm also connected with the Blue Door Clinic as one of the intake workers. And the Blue Door Clinic provides medical care to people living with HIV who have precarious immigration status. So it actually doesn't include refugees, but who it does include are visitors, international students, people on work permits, or people with no status.
Fantastic. So let's get into the questions. As I said, it's a fantastic, wonderful panel that we have, and I can't wait to get into it with you all. So question number one is going to be directed at Nishan. So moving to another country, context setting, particularly after fleeing as a refugee, can be a quite complex situation. Can you speak to some of the health and social challenges that LGBTQI refugees face before they arrive and upon first arriving to Canada?
Thanks very much, Andrew. Really important question. I'm happy to start us off here. I should preface my comments by saying that the data that I'm going to share with you, a lot of this comes from our upcoming 2022 annual report, which has not yet been published. So I just was sort of scraping through the data earlier and looking at a draft. So what I'm sharing with you is actually fresh off the books here and is yet unpublished. So I'll point to a few different safety concerns that I think distinct health implications that maybe family physicians might find useful as they encounter LGBTQI refugees for the first time. So the first one is that most people requesting help from Rainbow Railroad have reported experiencing family-based rejection and family violence. There are two particularly severe forms of this to be aware of. One is what's called so-called conversion therapy. This has recently been banned in Canada, but it's still a very common practice around the world. And it's a sort of pseudoscientific pseudo-medical practice of attempting to convert someone's sexual orientation or gender identity. And this has been called by the United Nations independent expert on sexual orientation and gender identity as a form of torture. And we see the kind of torturous consequences of that in our clients quite frequently. And so there are obviously distinct physical consequences and mental health consequences to that, depending on the form it takes. You know, in some contexts, it can involve you know, procedures as invasive as shock therapy. We've seen a wide range of interventions under this kind of umbrella category of conversion therapy. But the bottom line is that you know, it's quite a significant concern reported by our clients. I should also mention on the point of conversion therapy that there's a kind of a disproportionate distribution of this practice across regions. So we find that this is a more common practice in Latin America. So if you have, if you're working with patients from Latin America, you know, it's a more common practice there. Actually, 14% of our Latin American cases have experienced conversion therapy. So the second thing I'll mention under family-based rejection violence is corrective rape, and queer women, bisexual women, transgender women are disproportionately affected by corrective rape. It's often perpetrated by family members or close acquaintances, and it's an attempt, again, to change someone's sexual orientation through sexual violence. And so, of course, there are distinct health consequences that I won't draw out here, but two things to note there, so conversion therapy and corrective rape. Sort of second group of issues, again, tying to corrective rape is broader sexual violence. Here is so 1 in 4 people requesting help from Rainbow Railroad reported having survived a sexual violence. And this is, I should just add, up from less than 1 in 10 in 2020. So, you know, as the COVID-19 pandemic has really forced a lot of people to be confined to domestic environments, which has in turn increased their exposure to domestic violence and other forms of violence, sexual violence among them. So just want to highlight that this is a trend that we're seeing more and more in our work. And I should also mention that from our Caribbean caseload and also our caseload from South Central Asia and Sub-Saharan Africa, we tend to hear sexual violence reported more frequently. I want to mention here, of course, women are disproportionately affected by sexual violence, but we do find as well that queer men, especially those who've been in detention settings, especially coming out of the Syria crisis, have also been frequently subject to sexual violence in detention by both state and non-state actors. And for those who've received humanitarian assistance or medical assistance in transit countries prior to coming to Canada, often the specifically gender-based dimensions of that violence have often not been flagged. It might be called more broadly torture, and they might be referred to torture actors for specialized support and not gender-based violence and health actors. So I think it's important to note when you're working with queer men specifically that, you know, sexual violence is common in certain contexts and settings, especially for those in detention, but it might not have been identified prior to arrival. And of course, mental health continues to be a significant concern. We've noticed an 18-fold increase in reports of mental health concerns since the start of the COVID-19 pandemic. So it's depression, anxiety, substance abuse are really commonly reported among our clients here. And in part, this has been exacerbated, as mentioned, by reduced levels of access to care and even frequently denial of care in the wake of the pandemic. So wanted to flag that as well. So I'll leave it there for now. And of course, there's a lot more to discuss, but hopefully that's a useful introduction.
No, that's incredibly useful. It's there's a lot of trauma to recognize that may not even as a family doctor caring for somebody may not even you may not flag initially. So those statistics are incredibly helpful. Did anyone else? I want to give the rest of our panel a chance to add anything to that if they wanted to.
I can maybe add some things. More so, I think once folks have arrived in Canada, maybe some of the challenges that they face here. So I find that one primary thing is access to income. Is a huge issue because folks here, you know, might be leaving full-time employment or might be leaving a career back home and coming here and not really sure kind of where to start. and how much they can afford in this city. So then there's housing, among other things. So a lot of the folks that I do support are living in very temporary housing situations, particularly from the LGBTQI plus community. Like a lot of folks end up couch surfing or know one person who's a friend or met through a friend's friend and end up staying on a couch somewhere for a little bit. And sometimes it works out well and they're able to find supports for themselves, but other times, and this is more frequently, I think in my program, I see this because I work primarily with folks also that are homeless, is that they'll end up in shelter. And then from shelter, trying to navigate services here can be really, really challenging. Which also, I mean, I should say that language is a huge thing. So communication and language, so a lot of folks that are coming here don't, English might not be their primary language. And knowing kind of where to go and who to talk to is scary, especially when you're coming from somewhere where there is violence or you've been experiencing violence. And here you don't know who to talk to, what information you can tell them, even as a service provider. Like I often do intake assessments or I meet someone for the first time and I keep it super chill because people are very hesitant and they don't always know what to share. So that's kind of something I wanted to add.
That's incredibly helpful for us all to keep in mind for sure. And it leads very nicely into our next question, which I'm going to direct towards Mo. So based on your experience, can you speak to some of the types of services that are most useful to helping LGBTQI plus refugees first settle in their new environment?
Of course. So like that's my job. We work in the settlement field and we help newcomers like better adapt in the new communities. So first of all, I feel like interpretation and translation are one of the most crucial services needed because a lot of them have language barriers. And once you have these challenges with communication, it can be hard to find services. It can be hard to do your groceries, go get your medication from the pharmacy, finding a family doctor. So definitely this is very essential. Other services is again like finding income. So a lot of them, they apply to Ontario Work or ODSP for assistance, but still it's not enough because they provide very bare minimum for merely the basic needs. Sometimes it's $1,000, but we all know that $1,000 is nothing in Toronto or anywhere basically in Canada. Everything is expensive, especially with the inflation now. So other services is to connect to family doctors and help them navigate the healthcare system here in Canada, because not all of them are familiar with it. And they have sometimes some misconceptions because they might have an idea that healthcare is free, but they don't know that not everything is free. And sometimes they need access to mental health services, but this is one of the main barriers because sometimes you need to pay a fee for that service. Yet again, they are having these financial challenges at the moment. So that's why I always say mental health shouldn't be a privilege. It should be a right accessible to everyone. Another service that is needed is connecting them to link classes so they can do the language assessment. And based on their results, they can be put in the specific level where they can improve their language proficiency. It can be either in English or French. So basically, these are the most needed services. And of course, housing. We also help them apply to government assistance or subsidized housing. And sometimes we also help open a bank account because it can be complicated. So yeah, we literally have them in the day-to-day activities and to better adapt in the country and to build like connections and community. And lastly, we also help them break the stigma around sexual health or mental health, because a lot of them, they are not comfortable to discuss that, or they have never opened up about this discussion because it's a taboo in their home country.
Those are some really important things for us to remember to focus on, and we're so grateful that you're able to facilitate those services in your role. Does anyone else want to add to that, or
Yeah, I'll maybe add briefly that the knowing sort of local resources is going to be really important, because a lot of this stuff is really critical for someone's health, but may not be within the capacity of a family doctor's clinic. I think that there can be some multidisciplinary clinics that have social workers or other allied health professionals that can bridge some of this. But identifying the community organizations locally that can do that type of work is going to be really important. It is important to know, though, that particularly if someone's coming from a cultural group where there is a lot of stigma around being LGBTQI+, that might make it harder for them to disclose that part of themselves or that part of their history to other people from their cultural group. And so recognizing that this is a population that might be sort of uniquely alienated within an ethnic community within Canada, and might not be able to access community support from other people from the same country, but also might be reluctant to access things like social services. So sort of being sensitive around that and exploring it with your patient to find the right local resources.
Just to echo Ian here a little bit too, I think for some refugees, there might even be an active distrust of the medical establishment, depending on the context in which they're coming from. And that can be a significant barrier, not only to disclosure, but even to getting any kind of care in the first place. So I think what Ian mentioned, which is working as closely as possible with LGBTQI community centers, local networks, activist networks, et cetera, to really embed care in the community is really, really important.
Absolutely, and I think that's something that as family doctors, primary care providers, we want to make sure that we are remembering that and addressing these needs appropriately and in a sensitive manner. So for our next question, I'm going to direct it towards Simran. The ongoing transition and settlement of clients and patients can take a very long time, months to years. How do you support clients or patients for family doctors during this transition?
Honestly, at this point, I feel like I am sticking around for years, and that's just part of the process. I mean, communication is very key in supporting clients, because I think that, like we've talked about, like there's a lot of mistrust or just hesitancy and not being really sure who to talk to and what to say and what they can say or share about their lives. And as like a community agency provider, I'm in a, I think, very lucky to be in a position where there's more flexibility in the kind of supports that I can offer. So I'm very lucky that I can meet folks kind of where they're at. So that's part of what I really do try. Like I'll see people at their units or in shelter, or I'll go out on the street, like it's just wherever kind of they are. And one of the things I prioritize is making sure they understand what resources are available to them. So I see my role as just making sure that they have this information, that they understand it, that at least I'm somebody that they can ask as many questions as they need to. And then ultimately, it's about listening to kind of what their priorities are, because there's me as a service provider coming in and saying, oh, of course, you need this, 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 and this. But then that person, you know, even though they might want to attend volunteer activities, or maybe there is a job training coming up, maybe they have children, or maybe, you know, they're staying in a family situation where this program may out them within their family and they don't feel comfortable leaving, or they don't feel comfortable attending. And so trying to be really cognizant of that. So I mean, I'm again very lucky to be in a community agency where I can offer my space. Like I can be like, just come to my office. You can, I'm okay. I can work out of somewhere else. You can come and have your appointment here, or we can go together. Trying to like support folks to appointments, you know, just accompanying them, being with them, chatting with them. I often find that it's really about connection, and just for folks to know that there is somewhere that they can go and someone they can go to talk to. Because sometimes it can be like the bigger institutions, it's a lot harder to get in, and it's a lot harder to know what to do or who to talk to. And so just trying to do that as much as I can, and ultimately being very flexible. So if there's if you know, there might be a very important medical appointment coming up, but that person is saying, I can't go. And I'm like, okay, well, why can't you go? And maybe the reason is they don't have money for transportation. And I'm like, okay, I can drive there. I can give you tokens. Like, that's not a big deal. But then it's like, no, but I still can't go because I have this, or I have that, and I have this. And I'm like, okay. So then it's like, you know, strategizing and problem solving. And in the time of COVID, in some ways, we're lucky that we can offer virtual care. So there's alternative ways to provide services, even as family doctors, that in some ways I think maybe have become more flexible, but in others haven't. So, I mean, I leave that for physicians to figure out amongst yourself. But I mean, at least that being flexible, I find, is very key in being able to support folks.
Completely. Your clients, it sounds like your clients are very lucky to have you. And that it takes a lot of active listening. Mo.
So I just wanted to add that, of course, transitioning to a new country or a new environment can be stressful and takes time to settle. So the first thing is for the client to become fully vulnerable and to be their true authentic self and share their actual needs. You have to build this bond of trust, and this can be by providing a safe space, inclusive space with zero judgment policy. And once they trust you, they can like better communicate with you about their actual needs. Because first they have to be authentic with themselves. They have to break the stigma. Let's say if they are living with HIV, it can be very challenging to mention it or discuss it, or if they have like mental health challenges, sometimes they might be not aware of it or hard for them to accept it because back home, there's a big stigma around it. So it takes time. You need to build trust. And of course, active listening and having a healthy communication can help. And to reach that stage, it takes time. But of course, that's why we have like a lot of amazing service providers and organizations in Toronto and in Canada that has been helping a lot of refugees.
Nisha.
Thanks, Andrew. Maybe just one point to add. I'm not sure how useful it is, but I think it's important to remember here that also refugees come through different modalities. So we have privately sponsored refugees, government-assisted refugees, and they come with different degrees of support. So, you know, for LGBTQI refugees who are coming through private sponsorship, they're often immediately embedded in a community. They have people who are actively kind of helping them sift through the medical system, other newcomer services, et cetera. Other government-assisted refugees might not have the same type of support. And so I think the type of kind of refugee pathway into Canada also affects the length of time of the kind of transition integration process, and maybe the degree of comfort and willingness to kind of openly disclose some of these health challenges that we're mentioning. So I think getting a grasp on sort of who's in front of you, not just a generic refugee, but sort of where they're coming from in terms of their kind of legal pathway here and the degree of community support is really important as well.
Totally. You can't expect that everybody has the same connections to resources, and depending on what community they're in, where they are in the country, and what pathway they led them there. So I'm gonna direct the next question towards Ian, and he started to speak to it earlier. How can family physicians better support LGBTQI plus refugees in their practice? And I know this is something that obviously varies a lot depending on where you're practicing across the country, but I'm interested to hear your thoughts.
Yeah, thank you. So the two sort of things I wanted to talk a bit about were some areas related to the history taking, and then some sort of practical tips or things to be aware of. When it comes to history taking, of course, it's really important for us as family doctors to get to know a lot about someone's health, their mental health challenges, their past history. But like all of the panelists have mentioned today, I think that it can take a bit of time for the person in front of you to develop that sense of trust in you, or really for you to earn their trust, especially if they're coming from, if they have had negative experiences with authority figures or with the medical system in the past, that might not come easily for them to share certain sensitive details. Of course, it is really important for us to know about their past medical history. And so for LGBTQI refugees, some things that might be sort of unique or uniquely relevant are things like for intersex individuals, finding out whether this is at your first visit or at subsequent visits, asking whether they've gone through any sort of surgical procedures related to their intersex status or had any medical or hormonal interventions. Similarly, for trans or non-binary individuals, finding out whether they've had any gender-affirming medical or surgical interventions in the past. And that could include surgeries or prescribed medications, but there can also be non-medical ways that people can try to affirm their gender or affirm the way that their sort of embodiment goals. So for some individuals, that might include accessing hormones from non-prescribed sources or from like a black market. For people that are coming maybe from particularly trans women coming from countries where hormonal contraceptives are available over the counter. There might be people who have been buying hormones like estrogen or progestogens over the counter without any monitoring. And so when they arrive in Canada and don't have access to those treatments anymore, that can be really disorienting or can be a major problem. You might also want to think about sort of non-medical body modification like fillers or injections that can be quite prevalent in certain countries, and that would maybe influence someone's health status or health complications in the future. Again, this might be things that come up in subsequent visits, not at the initial visit, but just being aware of that. And then also wanted to mention with HIV, like Simran mentioned, sometimes people arrive in Canada and as they're going through their immigration medical, they find out here that they have HIV, or there might be people who have been living with it and aware of it for many years where they were coming from previously. So getting a bit of a sense of that and then referring them appropriately to an HIV care provider if that's needed. In terms of some of the more mental health related considerations. Again, with any sort of trauma, you'd want to have established some trust and establish that it's a safe space before asking specific questions about past trauma. But like Nishan was mentioning, knowing that things like conversion therapy, corrective rape might be things that these patients have experienced, that can be affecting their mental health and their day-to-day in ways that we wouldn't see with other types of patients. Knowing that there can be really negative or traumatic experiences, both in the environment they're seeking asylum from, as well as the refugee process itself, if they've had to stay in camps in transit countries. And then also knowing that you want to be asking questions maybe around maladaptive coping, for instance, with alcohol or with other substances that might be helping them to sort of get by day to day with carrying those burdens. I'm shifting over a bit to talk about some of the practical considerations. I think it is really important to note that if refugees have the interim federal health program for their medical coverage, that there are some subtle differences between what provincial health plans cover and what IFH covers. So for people with IFH, they actually are entitled to psychotherapy that's covered by the government, which most provincial or most parts of the country isn't available. So knowing that those resources exist is really important so we can facilitate them accessing psychotherapy. There are other things like physiotherapy, occupational therapy, orthotics that are also covered, medical devices, glasses, hearing aids, as well as some interpretive services if they're seeing a psychiatrist or a psychotherapist. So knowing that there are a couple of other services that are available to people covered under IFHP is going to be really key. One thing that IFHP does not cover is gender-affirming surgeries. And so I've seen a number of transgender refugees who are experiencing a lot of dysphoria around their body, but aren't able to actually access this type of care until they get permanent residency and then are covered under provincial health plans. So that can be a really challenging situation to be supporting someone in.
That's incredibly tough to navigate, because we want to be supporting our patients in the best way possible, but obviously it's not always so easy. So my next question, and I want to make sure we have time for the Q&A, which we're going to have to flip to shortly, to answer some audience questions, but as family doctors, we can all do better to create safer spaces for our to us LGBTQ plus patients. Are there any specific tips from any of you that you would give us to create safer spaces for our LGBTQI plus refugee patients? Mo.
Right, so I feel we kind of mentioned it, but other than them having experienced conversion therapy, a lot of them have been also rejected from their families and loved ones. So they kind of have dealt maybe with the depression, or not only that, they might have flee from like war zones, let's say Syrian refugees, or recently the Ukrainian refugees. And so there's a lot of intersectional challenges that they have been dealing with. So, like, of course, providing, as I mentioned before, a safe place, inclusive place, non-judgmental environment can be very helpful for them to be vulnerable and their true authentic self. Of course, working in an anti-oppressive framework as well, and being aware of their privileges. And basically, like, knowing where to refer them to the right resources as soon as possible, and not assume that they might need some mental health services, but like directly direct them to these services and inform them. Like, don't wait for them to ask, but let them know that these services are available. And of course, there's also an important thing, a soft skill, which is empathy. Is very important to have it, because you need to feel with others in order to help them.
That's a great tip. Thanks, Mo. Nishan?
Yeah, thank you, Andrew. Maybe just 2 quick points here. The first comes from my experience working in various sort of refugee registration settings for UNHCR, and it might have some spillover relevance into kind of medical settings. But one thing I really can't stress enough is how much the physicality of the space matters in sort of inclusion. So we found that little physical, kind of little visual representations of inclusion, like something as simple as a poster showing that the space is inclusive, or kind of a rainbow pin, or there are different ways and approaches to kind of signal inclusivity, but that those physical markers in the space can really invite openness and kind of conversation in a way that's really powerful for some people. So I think just thinking about like the physical setup of your space and the degree to which it signals inclusion is really important. And then the second thing that I wanted to kind of maybe picking up on something Mo mentioned earlier about family acceptance and rejection. I think really there are 2 kinds of LGBTQI refugees who you could have in front of you. The first is someone who has been persecuted specifically on account of their diverse sexual orientation, gender identity, expression, sex characteristics, and who has received refugee status and resettlement on that basis. And the second type of person, I think that's kind of often forgotten in this space, is someone who's been a refugee on other grounds, race, religion, nationality, but who happens to be queer as well. And I think, especially if they've been resettled with their families, there might be instances where their families might still they might be facing difficult and potentially dangerous situations with their families, despite being in Canada. So I think sort of inviting opportunities to discuss their current situation in the context of their families. I don't have any good tips on how to do this, but just being mindful that there could be ongoing situations of family rejection, violence that persist in Canada. And then recognizing from that your role as a kind of service provider and a referral agent to be able to connect them to non-medical services to respond to those situations of potential family violence as well. So I hope that's somewhat useful.
No, that's very helpful. Thank you, Nishan. So now we will go to questions from our participants, from our audience. The first question, I see there's two questions in the Q&A. One of them has already been addressed, was for Matthew Lee. Oh, it's already flipped to the answered, but it was about coverage for gender affirming surgery, and Ian had said that this is something that is not covered through IFHP, which is a very important consideration and a challenging conversation that family physicians would have to have with their patients. So it's an important thing to know about. The next question on the list was, do you feel as family physicians that the information collected and distributed to healthcare providers on the IRCC resettlement refugee forms is useful, sufficient? Any suggestions for the department? I will leave that open to anyone to try and tackle that or give an opinion. Is there anyone that would like to try and take that question on?
I'm realizing I don't think I've ever received an IRCC resettlement refugee form, like as a healthcare provider, and so I'm curious about what that aspect of the system is that I'm not aware of.
I would have to say I'm personally not familiar with the forms enough to get into it either. I'm happy for anyone else that is familiar with it, that has an opinion on this, that's with us today, to chime in.
I'm just going to speak. I think it's a parallel system. I don't actually think that as the primary, like as family physicians, we actually see it. I think it's a system that the refugee patients go through, and then it's separate, and only if there's an issue that's identified does it get pushed to us. So if it's identified that I've only seen it in the context of STI screening, and if a syphilis is positive or an HIV is positive, that gets pushed to us, but we don't actually get to see the full form that's done. It's really only if something needs to be addressed within the regular healthcare system, or is there any information shared with us.
And I'm not sure how often these forms do get updated, and how well they address some of the sensitive issues that our LGBTQI plus refugees face. So it's a good question, but one we unfortunately don't have a clear answer for today. Are there any other questions from the audience? So we still have a few minutes left. Was there anything else that, in terms of family doctors providing care to LGBTQI refugee patients, from our audience or panelists? I was going to say, is there anything that we can be doing better? Dr. Thea Weisdorf has her hand up, so I'll let her speak.
Hi, everyone. So thank you, everyone, for speaking so beautifully and eloquently. I wanted to just add, as a family doctor and who provides care to the 2S LGBTQI+ population, that it's building on what Nisheen said, was that not only is the physical space really important for as an important aspect to welcoming people and welcoming refugees, and language is also very important. And again, whether it's use of pronouns, whether even the term family means different things to different people. So as you said, family can be a very difficult conversation if there's been conversion therapy or the very difficult situation and not having support. But family can also mean very different things to people. And it's really important to ask people what family, like who are the people that they consider family. And it does definitely not have to be blood relatives, because other people can be very important supports to these patients, but and considered, you know, family to them. And so often people, my experience with working with people in the transgender community is that they have developed family supports, but, you know, from various different sources, and generally not from their direct blood family, but from other people. So really inquiring about who they consider family, who they find as a support is a really important thing and can be very helpful.
That's great. No, I think that's really useful to remember, and I think also allowing them the opportunity, if there is somebody that is within their family that they want to have present at appointments or things like that, that they have the opportunity to invite people that may create this the space to be safer for them. Mo?
Yeah, I just wanted to add something very briefly, that when we're working with services who are members of the LGBT community, we need to be aware that not all of them are out, and sometimes they have a lot of challenges. So there's no right and wrong time to come out. Only when they are like financially independent and they feel safe enough, they can come out. And another thing, do not assume the gender of the person you're dealing with, even if the person looks, for example, male. Always ask what are the pronouns you're comfortable to use. So, because it can be a very sensitive topic. So don't assume, ask about the pronouns.
No, I think that's very key to creating a safe space for all of our patients. We only have a couple minutes left. Was there anything else that anyone wanted to add before we wrap up?
I just wanted to say something quickly that I say everywhere, but just that, you know, there's a lot of learning that we can do ourselves every day. That's not always dependent on the person that we're seeing or the person that we're speaking to. And this can be simple things. It could be picking up a book. It could be, you know, using Google Translate or using an app to learn a few words in a language. If you see like a lot of clients that speak a particular, like for Blue Door, I think the majority of people speak Spanish. So I've picked up the most random administrative words, but I'm trying to slowly learn more than that. But just, you know, like really hearing kind of what people are saying to you and just doing these little things, because I guarantee, and I know this, that's part of that trust building. Like people see that you're making an effort. People see that you are genuinely trying to understand and know what they're feeling and where they come from and where they want to be. So that's just, yeah. So just do that do some of that learning yourself. Like encourage yourself to do that. That's just all I wanted to say.
No, that's good. That's great advice. I think we can all do better. We can all do better for our patients, and that's why we're here today. That's why we're tuning into this webinar. So I would like to thank all of our panelists for joining. Ian, Mo, Nishan, Simran, thank you so much for all of your fantastic advice for us, and for bringing your experience to this panel. I want to encourage everyone to fill in the evaluation. There's a link in the chat and you can get your main pro credit. That is all for today. Thank you so much for joining, everyone.
Thank you.